All right, let's dive right into this explainer, where we're going to break down the biological and sociological theories of aging, and more importantly, see how they directly impact patient care. We're taking the complex science of gerontology, the study of all aspects of aging and its consequences, and we're translating it into the practical, compassionate care strategies that professional nurses and caregivers use every single day.
So before we even touch the science, I want you to really think for a second. What stereotypes pop into your head when you hear the word elderly? Because we are going to challenge those head-on today. Do you automatically picture someone who's dependent? Frail? Maybe you just assume they're poor, lonely, or, unable to learn new things? These are incredibly common stereotypes, but bringing them to the bedside, that is downright dangerous.
And why does this matter so much right now? Well, just think about the demographic shift we're living through. Currently, older adults make up about 12.8% of the population. But by 2030, older adults will make up 20% of the population. That's literally 1 in 5 people. This massive shift is vastly increasing the need for empathetic, specialized geriatric care. We're looking at a future where understanding the unique physiological and cognitive needs of older adults isn't just some niche specialty. It's an absolute necessity for everyone working in healthcare.
Okay, here's our roadmap for this explainer. 1. Confronting ageism in healthcare. 2. Biological theories of aging. 3. Sociological theories of aging. 4. The realities of aging. 5. Supporting families and caregivers. And finally, 6. Practical strategies for nurses.
Section 1. Confronting ageism in healthcare, challenging our inherent biases.
We really have to start by looking in the mirror. The crucial point here is that ageism stereotypes older adults without ever looking at what they can actually do. It's a bias based solely on the number of years they've been alive, their chronological age, while completely ignoring their functional status. When a healthcare provider falls into the trap of ageism, they might assume an older patient is just being difficult or confused and totally miss a highly treatable underlying condition. Treating a healthy 85-year-old marathon runner exactly the same as an 85-year-old bedbound patient is just a massive failure of care. We gotta treat the function, not just the age.
Section 2. Biological theories of aging. Understanding the physical why.
Let's transition from bias to biology to figure out what's actually happening at a cellular level as our patients age. To keep it simple, we can put this complex biology into 2 main camps, stochastic and non-stochastic theories. The stochastic theories argue that aging is just a series of random events that accumulate over time. Think of the wear and tear theory, where cells simply wear out like, parts in an old car engine. Or the free radical theory, where byproducts of metabolism slowly damage cell membranes. On the flip side, we have non-stochastic theories. These view aging as a predetermined, genetically timed phenomenon. For instance, the program theory, which is often called the Hayflick limit, suggests our cells can only replicate a specific limited number of times before stopping. Or the immunity theory, tracking the programmed age-related decline of our immune system, making older adults way more susceptible to infections and autoimmune issues. In reality, most experts today believe human aging is a combination of both, random environmental damage interacting with our internal genetic clocks.
Moving right along to Section 3, Sociological Theories of Aging, the human experience of growing older.
Aging isn't just biological, right? We have to look at how older adults interact with the world around them, and this is where the activity theory comes in. It directly shatters that frail and dependent myth by emphasizing that staying active maintains a positive self-concept. Developed way back in the 1960s, this theory is beautifully simple but profoundly important. It argues that activity is absolutely necessary for life satisfaction. It boldly states that it's better to be active than inactive, and better to be happy than unhappy. But here is the most empowering part. The older individual is the best judge of their own success. It is absolutely not up to the nurse or the family to dictate what a successful day looks like. If a patient defines success as independently walking over to the window to watch the birds, then we support that activity 100%.
Now imagine your environment changing faster than your sensory capacity. That is the person-environment-fit theory, and it's a massive driver of the frustration some patients exhibit. This theory, proposed by Lawton, notes that we all rely on personal competencies, things like motor skills, ego strength, and sensory perception, to navigate our world. As a person ages, those competencies might decline. Suddenly, the environment they used to navigate with zero issues, like a kitchen with really high shelves or a world that relies entirely on smartphones, no longer fits their abilities. And that mismatch, it causes tremendous stress.
Section 4. The realities of aging.
bridging theory to cognitive and physical changes. Let's see how all this theory builds into the tangible cognitive and physical realities you'll actually face on the nursing floor. Now, while mild short-term memory loss is a totally normal part of aging, your long-term memory usually stays perfectly intact, by the way. You have got to stay incredibly vigilant for the 3 Ds: dementia, depression, and delirium. These represent abnormal cognitive aging. Dementia is a severe progressive loss of memory and cognitive function. Depression is incredibly common but super often overlooked in older adults, sometimes even mimicking memory loss. And delirium? That's a sudden, acute state of confusion that is often a huge red flag for an underlying physical issue, like a urinary tract infection. Being able to distinguish between a normal, slower reaction time and the acute onset of delirium can literally save a patient's life.
Think about what happens physically over time. Physiologically, all systems decline in their overall functioning. The central nervous system responds slower. Blood vessels become less elastic. Renal blood flow decreases, meaning waste products are excreted much more slowly, making fluid balance incredibly fragile. Even things like taste and smell diminish, and that directly impacts a patient's desire to eat, which can lead straight to malnutrition. When you combine those slower reflexes with diminished hearing and fragile fluid balances, it's so clear why older adults require modified pacing and extra rest periods during care. As a caregiver, you have to factor all of this into your daily plan. You just cannot rush a patient whose physiological reserves are already tapped out.
Section 5. Supporting Families and Caregivers, the Interconnected Care Web.
Because patients don't exist in the vacuum, we have to look at how these realities impact the families supporting them. Here is a vital truth. Caregivers communicate their own fatigue and stress to clients. Family stress is contagious. It directly impacts your patient's well-being and anxiety levels. When we talk about geriatric nursing, we aren't just treating the individual in the bed. Half the time we're managing a whole family unit. If a daughter is exhausted from providing 24/7 home care, her fatigue and short temper will absolutely be felt by the older adult, who might then become agitated or withdrawn. To combat this, your communication strategies have to involve actively listening to family members and teaching them to recognize their own burnout before it spills over to the patient. And this dynamic creates the perfect storm for sundowning syndrome, which is when a patient suddenly becomes confused or agitated at night. Sundowning is fascinating, but it's really complex. As the sun sets, several things hit all at once. Dimming light makes an already diminished visual capacity even worse, which naturally increases fear. The patient's biological clock triggers hormone imbalances. They're totally exhausted, so their usual coping mechanisms just fail. And right at that exact moment, the caregiver, who is also at the end of their rope, communicates their own fatigue. It's a perfect storm of confusion and restlessness. By understanding this web of causes, nurses can step in earlier in the afternoon to create calmer, more supportive environments.
Section 6. Practical Strategies for Nurses, Transforming Theory into Compassionate Care.
So how do we actually take all this theory and biological data and use it to improve our daily nursing practice? Well, your actionable steps are pretty clear. Actively promote health through targeted teaching. First up, focus on nutrition and exercise. Remember the activity theory? Exercise makes older adults more functional, not less. You just have to tailor it to their current ability. Second, because of the biological immunity theory we covered, staying on top of immunizations is absolutely critical. And third, watch out for polypharmacy, the use of multiple medications. Because their renal flow is slower and their fluid balance is so delicate, older adults are highly susceptible to drug toxicities and adverse interactions. You've got to manage those meds closely.
It's all about being proactive. By anticipating specific nursing diagnoses like the risk for falls or wandering, you are practically applying those biological and sociological theories to keep the patient safe. You're not just reacting, you're looking 2 steps ahead. You know their sense of balance declines and their joints stiffen, so boom, you immediately flag them as a fall risk. You know they might have ill-fitting dentures, altered dentition, so you monitor their eating habits so they don't face malnutrition. You know their environment might not fit their changing competencies, leading to isolation, so you actively monitor them for the risk of loneliness.
And sadly, we also have to talk about the heartbreaking reality of elder abuse. We must always keep a watchful eye for any deliberate action or even negligence that harms these vulnerable individuals. It isn't just physical violence either. It can be sexual, emotional, psychological, or even financial abuse. And while it can certainly happen in facilities, it frequently happens right at home. As a healthcare professional, your vigilance is quite literally the last line of defense for a patient who might not be able to advocate for themselves.
Ultimately, armed with this deeper understanding of the aging process,
From the cellular wear and tear all the way up to the sociological need for meaningful activity, I'll leave you with this final question. How will you actively prioritize dignity and dismantle ageism the very next time you step into a patient's room? Will you just see a chronological age on a chart, or will you see a lifetime of experiences paired with a unique set of functional capabilities? The choice and the quality of care that follows is entirely in your hands. Thank you so much for joining me for this explainer. Keep learning, keep advocating, and I'll catch you next time.